It's good to be back in Orlando. We had a similar group last year, but I never give the same presentation twice. So we've got lots of different updates to share this time and some Florida-specific focus, as well as some new federal updates and a focus on how DPC interacts with large employers. So those are some of my current roles there. We'll jump right into it. Outline, state legislative update, federal legislative update, how to go about getting better price transparency throughout the system beyond the four walls of your primary care office, and how to work with employers. So what does it look like right now across the country? These are the states with direct primary care laws in place. The purple doesn't quite contrast as much with the rest of them, but if they're green, yellow, red, or purple, they currently have DPC laws, which covers 17 different states. Some of the earlier states didn't necessarily help DPC physicians as much as they'd intended, and Oregon would land in that boat, as would West Virginia. West Virginia is now purple because they're considering a revised law in the current legislative session. The other blue states are considering DPC law for the first time. We had around 7 that were passed back in 2015, another 3 in 2016, and this year could be the most successful yet. Several of these blue states already have bills in place. In Montana, it's Senate Bill 100, Colorado, House Bill 17-1115, Kentucky, it's Senate Bill 79, Indiana, Senate Bill 303, Georgia, Senate Bill 50, South Carolina, House Bill 3546, and Senate Bill 276. All these are well written, and they've talked with the DPC Coalition beforehand, so they're all worth supporting. And then, of course, Florida, which we'll talk about a little more today and is in your packet as well, Senate Bill 240 and the companion bill in the House, which is 161. So what's happened across the country? In the past 2 years, we've doubled the number of DPC practices. We now have 560 practices across 47 states. Everybody is represented except for the Dakotas and Iowa. And what's it look like in Florida? You've got 26 different locations that I've been able to find. Most of them have a green dot there, which means they're a pure DPC practice, as opposed to a red dot, which is a hybrid. Yellow, we weren't quite sure based on the website. So if we're going to look in a little more detail about what a Florida DPC physician would want to know, the way you start your analysis is, what is the definition of insurance in this state? Because I want to make sure the insurance commissioner doesn't put me in this box. When you say you want to open a membership-based practice and have everybody pay you a flat fee per month, the first thing that insurance commissioner worries about is, what if you take on 10,000 people, you couldn't possibly serve all these people? What if it's flu season and now you promised them you're going to see them and you can't do that? This is the unauthorized sale of insurance. They take it to the extreme. And so we have to defend against that. And the first way to do it is to look at the code. So there's the definition of insurance in Florida. It's a fairly benign definition as far as they go. Notably, some prepaid service plans have been explicitly excluded from the definition of insurance in Florida, which is kind of an interesting wrinkle. It won't really help DPC physicians too much. The other definition that you look at, because you typically don't want to be in this box either, is you don't want to get yourself labeled as a health maintenance organization, which seems really strange to think about since an HMO is supposed to price fix and cover everything from emergency care to ICU stays. But some states do have things called limited service HMOs. The easiest way for most DPC physicians to get out from under this label is to simply not charge on a prepaid basis. If you take some money up front, you do that in the form of an enrollment fee, and then the monthly fee occurs after the fact. And by billing in arrears, meaning at the end of the month, boom, there's no argument that you're an HMO, unless you're in one of the rare states that doesn't have that prepaid term there. In Florida, they do have the prepaid term, so it's one easy way out. Okay. So DPC legislative update in Florida. So this is the Senate Bill 240 and House Bill 161. If you look in your packet, you should have copies of these with you right now. And if you'll humor me, I'll run through the House Bill version. They're actually they're the same, but at the bottom of page 1 is where the language actually starts. And they start to define a direct primary care agreement. They say it means a contract between a primary care provider and a patient, and the patient's legal representative or an employer, which meets the requirements of subsection 4, which we'll get to a little bit later, and importantly, does not indemnify for services provided by a third party. That last part there, does not indemnify for services by a third party, is kind of unique to Florida. I haven't seen that mentioned much in the other 17 states. And so what would that mean for you? I've seen a few DPC practices contemplate, I've never seen it written in the contract, but contemplate saying, hey, my goal here is to give you something close to 24/7 coverage. If I'm out of town and I couldn't come in and suture you up when you cut yourself, I tell you what, go to the urgent care and then I'll pay your bill later. You can't do that in Florida, not if this passes as written because of that specific phrase. So that's one thing to be aware of. On page 2, you've got paragraphs B and C basically speak to the overall scope, and which fortunately is written to be broad here. They're not restricting your scope beyond what you're comfortable doing yourself. Paragraphs 2 and 3 have the all-important not insurance discussions. And then at the very end of page 2, going over into page 3, you've got the actual remainder of the definition of DPC. And the interesting part for Florida is, at the end of page 3, they actually have a mandatory disclosure provision, and they have 2 different ones that have to appear in that exact format in the contract. It's not uncommon to have a mandatory disclosure saying that this is not insurance. It's part of a patient protection. But in Florida's case, they actually put their double dipping provision in the exact same area. So this phrase says, this agreement is not health insurance and the primary care provider will not file any claims against the patient's health insurance policy or plan for reimbursement of any primary care services covered by the agreement, which makes sense. It's just in an odd place. So this is what I refer to as the double dipping prohibition that distinguishes DPC practices from fee for non-covered services practices, commonly known as concierge. Okay, that was a little bit dense. Hopefully that made sense, and we'll move on here. For anybody who's from Florida and wants to come to the hearing on this legislation, it's February the 8th from 3:30 to 6 o'clock in Tallahassee. I'll be there remotely. Dr. Lee Gross, who lives in Florida, will be there in person, I'm fairly certain. Josh Umber will be speaking as well. Okay, Florida Medicaid. State Medicaid laws were changed pursuant to the ACA, and it used to be the Medicaid program could pretty well decide on their own at the state level whether or not they were going to fill your orders. You didn't necessarily have to be enrolled in Medicaid to have your orders filled. So Dr. Huntoon just talked about the process for you to opt out of Medicare, and as long as you have an NPI and they know who in the world you are and you're enrolled in PCOS, when you order a lab, prescription, whatever, they do it. Medicaid is different. In most states, you have to sign up so that they know you exist, even though you intend to never bill them and you intend to privately contract. In Kentucky, it's a problem for separate reasons. You're just not able to privately contract with a Medicaid patient, period, regardless of whether you've signed up with Medicaid. But Florida should be like most states where you sign up and then tell them your intent to privately contract, and it's still possible to do that. Okay. What are we doing federally? So this is most of the DPC coalition work where I volunteer as general counsel. So Jay Keese is the executive director there. He spends all his time in DC following these issues really closely. The first bullet point is a nice win that we had, sort of unexpected. I think National Federation of Independent Businesses should probably get a lot of credit for this. It passed in the CARES Act in December. So the IRS has no idea what direct primary care is. They get very confused by it in spite of the fact that we have 17 state laws that discuss it, and it was discussed in the Affordable Care Act, with the Affordable Care Act referencing Washington's state law for a definition. The IRS says that this isn't quite insurance, but we still think it's some kind of plan. And because it's a plan, if you have DPC, and you otherwise had a high deductible plan that would have qualified you to have an HSA, we're going to say that by the nature of your DPC membership, you're no longer qualified as having a high deductible plan. We view this as some kind of first dollar coverage that would push you below that high deductible threshold. Thus, you can no longer contribute to your HSA. That's their first erroneous conclusion, and we have a letter from Koskinen saying this. Their second erroneous conclusion is that because it's a periodic fee, it must not really be a medical service. So even if we didn't view it as a gap plan, you couldn't use the HSA to pay for any of your DPC monthly membership fees. Now, to the extent the practice were to itemize things, then they never would have cared. They don't have a problem with cash pay, fee-for-service medicine. They just don't know what to do with the monthly fee, apparently. So those were the two big hurdles that we've been dealing with for a while. And the third one that showed up, all related to this same 213D misinterpretation of the code, was if you were a small employer and you had less than 50 employees, you were not required under the ACA to buy insurance for those employees. However, if you decided to offer them some kind of plan that was less than the full scope plan contemplated by the ACA, you could be subject to a $100 per day fine per employee. So there was talk about whether or not, if they're viewing DPC as a plan, would they throw it in that box, and Koskinen seemed to imply that they would. So obviously small employers, this makes them very gun-shy to pay for DPC with pre-tax dollars. That problem was fixed with the CARES Act, which got rid of the $100 per day fine. We still have the gap plan problem and the 213D eligible medical expense problem, and that's what we're hoping to solve with the Primary Care Enhancement Act, which maybe will be passed on its own or maybe bundled into something else. And then the second possibility, which could happen sooner, is that President Trump might have an executive order that would simply solve this misinterpretation. To our knowledge, the IRS has no intent to litigate any of these things, but nonetheless, they're obvious barriers. There have also been speculation that there would be a Medicare pilot or even a Medicaid pilot to be involved with DPC, and for obvious reasons, everybody gets kind of worried about that. If all they did was pay the bill, that would theoretically be okay to a lot of DPC physicians, but they remain skeptical. States have been experimenting with DPC, mainly in places where it's easier for them to experiment. So historically, that's not been Medicaid because they would have had to apply through several different waivers to actually use DPC to pay for it. But they have used it for state employees, most recently in North Carolina and Colorado. And as they have more flexibility in Medicaid, we anticipate to see some DPC experimentation there as well. Okay. So enough of the policy stuff. How do you go about actually achieving price transparency beyond what you do literally as a physician? And these are some of the biggest places you can make a difference. Medications are about 17% of the total healthcare spend, and that's one area that you can really get a hold of if you start dispensing medications in-house. We'll see that there are some states where you're not allowed to do that. Labs, you can negotiate those prices in advance. Let Quest and LabCorp fight for your business. And if they're not doing it, then find some local hospitals or other independent groups that will actually fight for your lab services. Radiology, it's pretty easy to get transparent pricing there as well. And you can leverage a lot of other lists that are out there. Jay Kempton, who is friends with Keith Smith in Oklahoma City, has some wonderful resources that list a lot of different radiology prices that you can use to leverage in your area, even if you don't live near where they do. Pathology, there's some barriers there, some oddly titled direct billing laws, which we'll get into a little bit later. Specialists. So if you're a primary care doc, you're likely to meet a lot of specialists in this room who are of the same orientation you are. If I lived in New York, I'd be talking to Dr. Huntoon about cash pricing for neurology. He's opted out, so there's a pretty good chance he wants to have those types of conversations. So find independent physicians, especially those who have opted out, and make those networks open to yourself and your patients. Surgery centers such as Oklahoma City, where Keith Smith's at. I think most folks have heard of that by now. And then independent and smaller hospitals are more likely to give you cash pay prices than large systems. Okay. In-office dispensing. If you're in a green state, you're good to go. If you're yellow, you can do it, but it's a hassle. I've talked for some physicians in Maryland that have gone through that process. It's lots and lots of paperwork and some fees, but it can be done. If you're in a red state, forget it. It's not really possible. Texas and Utah are actually some of the very harshest worded. I think Texas has wording to the extent of, yes, you can do this, but it's only for 3 days of supply and only if you're at least 20 miles from a pharmacy. So, you don't want to have your patient come back every third day for their entire year, so that's not really feasible there. Florida, is it a problem? No. You guys are a green state. I would certainly avoid doing controlled medications in this manner, especially in a state like Florida. I think a lot of this has changed, but as of a few years ago, 85% of the narcotics in this country were prescribed in Florida, and a lot of those were cash pay clinics with people walking out the front door with a bag full of narcotics. So don't put that radar on your back, especially when you're doing something that may or may not be politically popular. So contrast this with Texas, which we already did, and Maryland, which I already did. Lab pricing, again, bounce it back and forth between LabCorp and Quest. Find as many alternatives as you can. There are a few states, basically New York and New Jersey, the only ones I've found, where they don't like you to have any kind of pass-through pricing, where the lab is basically required to bill the patient directly unless you find yourself in some exception and you want to turn yourself into an HMO or a hospital. The insurance commissioner has written a letter in South Carolina indicating that theoretically she would be concerned if you started to bundle these lab prices into your monthly membership fee. It's something that most practices don't try to do anyway. Some of them have bundled it into a per visit fee because they say, hey, I'm doing a CBC and a CMP really often. These are like $3 or $4. Why don't I just charge you $20 each time you come in, and we'll just call it water under the bridge and not have to itemize things. That might not get as much attention, but in any event, my general recommendation is when it comes to labs, pass it through at that low cost you've negotiated and brag about it. Just like when you check out of the grocery store and you get something on sale, they tell you how much money you saved. So put your price there, put the hospital's price there, and make it one more value add. Pathology direct billing laws. So this is not the labs we just talked about. This is the skin biopsies and what have you that you're going to send to pathology. If you're in a green state, don't worry about it. If you're in any of the others, you need to pay attention. The way these are worded is that I think it was out of fear in the dermatology sector that dermatologists would negotiate some lower rate, and then rather than passing on that low rate to the patient, they'd mark it up. And then they wouldn't tell their own patients that, hey, this pathologist charged me $50 while I charged you $100. So a lot of the red states said, we're not going to allow that at all. The pathologist must, whether they want to or not, directly bill the patient. So typically the way you get these low rates from LabCorp, from the radiology group, and from a pathologist, if you're in one of these states, is you take away their burden of chasing down a patient and making them pay a bill. You say, hey, the minute I send this to you, the money comes to you, it's over and done with. And that's why those rates are low. So this is a frustrating point for a lot of places. In Florida, you can do it. You just can't mark it up, which most DPC practices wouldn't anyway. So if you're disclosing all those prices, you can send it to Cold Diagnostics, for example, which is a popular one, I believe, out in Idaho. It's around $40 for a skin biopsy. So take note of that. Specialists, I think I already jumped into this a little bit. They can charge rates below Medicare even if they've remained in the system. That's a common hurdle that we hear about these days that really doesn't exist anymore. That was changed a few years ago with the HITECH Act. You'll have a list of procedures that you want from them as well as some sort of rate for their time. I do think this is one of the best uses for telemedicine these days, especially in a DPC practice, especially if you're paying the specialist some cash pay rate. You would imagine in certain rural areas that maybe the neurologist isn't right next door. So instead of having the patient drive an hour to them, hoping the patient's going to remember all the history, all the relevant points, you can say, hey, why don't we, me, the family doc, and you, the patient, get on the video camera with this neurologist at the same time. And then you have excellent communication. So it's kind of an overlooked area that I think DPC practices could be doing more of is the telemedicine specialty consults. Be wary of any pricing arrangement that doesn't directly charge the patient. That goes without saying. Okay. Medical tourism, we have this occurring both domestically and internationally. And I got some examples about hepatitis C on the next slide. So, if you get Harvoni here in the United States, which is 12 weeks, 1 pill a day to treat your hepatitis C, it's going to cost you close to $100,000. If you decide to take a vacation to India or Egypt, you're looking at around $1,000. And I don't expect this to change for several years. So this is an obvious, easy example for reasons to do international medicine. Working with employers. Okay. So you'll want to contract with each individual patient, even though in Florida, for example, your law says that if the employer is paying the bill, they can sort of sign it on behalf of the patient. Always use that as a way to introduce the patient to the practice. Never rely on any conversations they might have had beforehand, otherwise you wind up in the old arranged marriage days of capitation, and that's confusing and messy for everyone. Different employers have different needs based on their size. If they're 50 or less, they're probably not going to ask much different of you than what you're already doing. The larger they get, the more data they want, because they're footing the bill and they want to see where the money goes. You have to be able to do that in a way that is blinded so that it doesn't violate patient privacy. That's why you aggregate it and de-identify it, and do that on your terms. So the other temptation that commonly DPC physicians face when they start wanting data is employers are used to looking at data the way the rest of the system looks at data. So they see the regular 99213s, they see the CPT codes, and they want to see those apples to apples or oranges to oranges comparisons, and most DPC practices don't code. And when you ask them to start ghost coding, you devalue a lot of that process. You have to decide if you're going to have a clinic that's on-site, meaning on the premises of the employer, near-site or both, depending on the size. The 50 to 100 group, mentioned level funded there. The 150 plus is a stop-loss type orientation, and then you have the really large ones that are known as captives. So what do each of those terms mean? A stop-loss insurance policy is basically the way in which employers have that catastrophic plan you all wish you could buy, but they can buy it. Individuals can't, but they can. So what happens is, if you're big enough, you say, hey, I've got $200,000 cash on hand, I can just pay out each claim until I hit $200,000. And then I want the insurance company to come in and start actually paying these medical claims. So if I do it that way, it's a lot cheaper to buy the insurance than if they're paying all the claims day one. So that's why they call it stop loss. At a certain amount, they stop your losses and they start paying it. Even for claims below the stop loss amount, you have access to that network and whatever the rates are. So if you bought the stop loss from Cigna, then you have Cigna rates. Bought it from Blue Cross, you have Blue Cross rates. If you're a little smaller and you can't quite be comfortable with the theory of paying out $200,000 or $500,000 or whatever, you can go with what's called a level funded plan. So there, they basically get you the same thing as stop loss, only they figure out the amount that they want you to pay. Maybe you were only comfortable with $100,000, or let's make it $120,000 so you have easy math. And then they say, if your $120,000 was your limit, you're going to pay us $10,000 each month. And then at the end of the year, if you were below that, we'll give you a refund to a certain amount. So it achieves the same thing, but a lower risk profile. If you're a captive, that means you were so big, you didn't need anything from Blue Cross except maybe their network and their rates, and you are paying everything. And Rosen Hotels is an example here in Florida that did that. Okay. The other terms that you'll need to know when you're interacting with employer groups are these terms here. So brokers, those are the guys that sell you, or sell the employer, the insurance product in the first place. Just like you'd have a broker for buying, maybe an independent broker for buying car insurance, these employers have independent brokers for making these decisions. A third-party administrator is the person who actually does the work of looking at all these codes and paying things out. So the physician sees somebody come in the office and they see Blue Cross or Cigna, and that may or may not go to the same third-party administrator. There's lots of independent ones out there that take a certain percentage, a per member per month fee to do what they do. There are other times when the insurance carrier actually fills that role as well. And in those cases, they tend to charge an even higher fee than an independent TPA, so that's kind of a bad idea. And the way the carrier fills it isn't necessarily by labeling it themselves, but they label it an ASO, an Administrative Services Organization. The average PMPM for all of these things, if you start adding it up, is around $30 a month, which is kind of crazy. But when approaching small employers, if 50 or fewer, you'll point out that the recent tax changes have taken place, so they don't have to worry about that $100 per day fine. That was a biggie. That one's gone. They're probably not going to want a lot of data, so you're not really going to have to change things too much. 50 to 150. The groups like Allied National out of Kansas sell a lot of self-insured or sell a lot of level-funded plans, and they love it when you find a DPC physician, and will often give discounts when that happens because they know the DPC physician is going to save them money down the road. Okay, and these are things to expect with large employers. I think I already mentioned some of these. The thing to be concerned about when working with some brokers is that they don't necessarily have the same rules in place that physicians do. And, you know, if I told you, yes, the patient comes into your office, the patient pays you for your services, and when you write a certain prescription, the pharmaceutical company is also going to pay you for that prescription, everybody in the room is going to cringe, right? That's an obvious conflict of interest. That's totally illegal, no matter how you slice it. That same conflict of interest occurs with brokers, and it's not illegal. So you have to be very careful of who you work with. Okay, price transparency opponents. So this should be pharmacy benefit administrators, or more commonly known as PBMs, pharmacy benefit managers. And we also have health plan brokers, which I sort of mentioned a minute ago, and then the large hospital systems. All these guys hate it when you shine a light on the ridiculous charges they're making, and as a DPC physician, it becomes part of your goal. So what do the PBMs do? They've got several games that they'll play. PBMs were invented to theoretically lower costs and use their size to negotiate lower prices for medications. And they realized that wasn't very lucrative, so they started doing other things. So they'll play a spread game where they tell one person it's one price and tell somebody else it's another and just take the middle. They will do a packaging and repricing game where they'll say, hey, if you send these patients to this mail order pharmacy, we'll give you a 50% discount on all the meds. And what they don't tell you is their starting price for lisinopril might have been $20, whereas the starting price at Walmart was $4. So now you're paying 10 instead of 4, but you got 50% savings. They also have a rebate game, and this one's the worst in my opinion because none of it's disclosed either, where if you write this is mostly on your name brand medications, they just have a kickback. I mean, it's as simple as it sounds. If you go to Walmart and buy a printer that has a $20 rebate, it's up to you to fill out the paperwork and send in the rebate and get your $20. And in this case, the rebate goes to Walmart instead of you. That's what they're doing. If you ask me, it's fraud. So the solution, if you want to get rid of these groups, is to dispense your own medications. That cuts them out of the process. If you're not using the plan, they don't have a chance to step in and take all these cuts that don't need to be there. If you use GoodRx, it's another cash pay way to do it, and just avoid using their plan at all costs. To give you an idea, they haven't totally gotten away with this, but they've gotten away with a lot of it. There have been 6 lawsuits with $371.9 million in damages awarded so far, and even some of the health plans have hated these guys so much that they've been buying them out. There's around 3 large ones that make up 80% of the market. Express Scripts went from a $1 billion revenue company to a $100 billion revenue company in just 20 years by changing it and playing these spread games and rebate games. Okay. This I sort of already mentioned, so I'll skip that. Large non-tax-paying hospital systems, that's my preferred term rather than nonprofit, is non-tax-paying. They like to mark up their prices and not disclose them either. And they like to make sure their physicians have no time to see their patients, because if I only give you 5 minutes, then you're going to refer, and everybody can keep dipping into that pocketbook. They game the outcomes data so that when those 9% bonuses come in, they're going to get them. So a few review questions here. Does Florida prohibit discount medications, labs, or pathology fees? Anybody remember? No. You're good to go on all of those. Does Florida have pending DPC legislation? Yes. Can Medicare and Medicaid patients join your DPC practice in Florida? Yes, if you sign up with Medicaid and opt out of Medicare. Do you need multiple LLCs to do all these things? This I didn't directly cover, but I get it all the time, so I figured I'd work it in. The answer is generally no. The main reason to have more than one LLC is so that you can play games with the insurance companies if you're trying to run a hybrid practice. And in that way, you'd have one practice would sign up at the practice level with the insurance company, not the physician level. And then you could say, hey, in one setting, I'm willing to see your patients at this rate, and in another, you didn't have any jurisdiction to tell me to do otherwise. Okay, and should you pay a broker to bring you patients? No. Lots of reasons, but beyond the ethical and moral ones, it could be unlawful fee splitting as well. Here's a few upcoming DPC events, just for those that are curious. And here's my Twitter and email if you need to reach out. Happy to answer questions. Thanks.